series, episode 6 on themed cataract. The question that we are looking at today is spectacle independence following cataract surgery. How real is the promise? Cataract surgery has always been the bread and butter of most of ophthalmologists, and we have always had this traditional golden goal of 6 by 6 and N6 with glasses. We even tell our patients that after surgery, you will need glasses either for distant vision or for near vision. But times are changing, new goals are emerging, the bar is being set higher and higher. So now the trend that is catching up is to promise spectacle independence, that is, to promise uh, good distant vision, intermediate vision, and near vision, even without glasses. Is it really possible? Is it feasible? Is it even desirable? Or are we opening another Pandora's box of unrealistic patients' expectations, which we surgeons will struggle to meet in future? These are some of the aspects we will be looking at in the coming 1 hour. And as usual, we will be starting with appraisal of evidence. The article being selected today is a patient-reported outcome, that is PRO, an article that is dealing with patient-reported outcome measures following cataract surgery, describing their satisfaction on spectacle independence. And this is taken from the BMC Ophthalmology 2024. And as usual, we have Dr. Praveen Nirmalan, our very competent research mentor. He will be taking you through the nuances of the article, and even the most complex concepts will be made very lucid and simple in his characteristic style and manner. We are also very privileged and honored to have with us two clinical experts of great stature. They are eminent cutting edge cataract surgeons familiar to all of us. We have Dr. Marie Paul with us today. She is the pioneer phacosurgeon, and she is now the medical director of Trinity Eye Hospital in Thrissur, and she is the pioneering phaco-refractive surgeon in Central Kerala. We also have with us equally eminent Dr. Minu Mathan. He is the senior consultant in cataract and lens refractive surgery at Chaitanya Eye Hospital, Trivandrum. He is also a international speaker of international repute and a crowd puller speaker, crowd puller faculty at most of our conferences. So it is a true delight to have both these cataract surgeons, Dr. Minu Mathan and Dr. Marine, together on this platform, on the KGO platform with me today. I extend a very warm welcome to both Dr. Minu Mathan and Dr. Marine Paul.
Thank you.
Yeah. So before we go into the scientific session proper, as usual, let me take this opportunity to announce the winners of the quiz, the KGO quiz based on last episode of the webinar that was focused on neuro-ophthalmology. And the winners are Dr. Manju M, consultant in glaucoma, Arya Eye Care, Thrissur, and Dr. Aishwarya from the KPM City Medical College, Kozhikode. So congratulations to both the winners, and do keep quizzing with KGO. As you know, the winner of the series will be awarded during Drishti 2025. So with that introduction, now let me hand over the session to Dr. Praveen. He will be starting off with the appraisal of the article. Dr. Praveen, the forum is yours.
So good evening, and let's look at the article for today. Factors influencing outcome satisfaction after cataract surgery. Patient-reported insights from the RAPRO database. This was published in 2024, December. So it's a recent article. It's from a particular database. The question of interest for this particular article was determinants of patient satisfaction following cataract surgery and patient-reported outcome measures. The key point to keep here is it's patient-reported outcome measures, and that's a area that's gaining prominence in an area worth exploring. Now, when you read a paper, we have been doing this for 5 sessions till now. So when you read a paper, just re-emphasize. The idea is to interpret in the context of limitations. Every study will have limitations. So the idea is not just to pick out limitations or find faults. That's not an aim. People do studies to find an answer to questions that interest them. Hopefully questions that interest them. Hopefully that's why they do a study. But most often that's why they do a study. They find results and they're willing to go the extra mile to share them and possibly face flack that you didn't do this, you didn't do that, that is not there, this is not there, blah, 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 blah. So there's a certain amount of courage in sharing the results for whatever reasons. We need to interpret their results in the context of our clinical experience. That's the idea of reading a paper. You want to interpret their results, the results that are put out there in the context of your clinical experience. What you find in your clinical experience might be similar or different. Think over why that is so. So you read a paper to reflect and then hopefully try to apply those results into your clinical practice. Moving into methods for this particular study, it was a multi-center retrospective observational study. Analyzing the PROMs, that's the patient-reported outcome measures, recorded in the RAPRO database from May 2019 to February 2024. So you have about 5 years, nearly. Inclusion criteria were age greater than 18 years, uneventful cataract surgery, valid consent for the study, and at least one questionnaire response. I had the questionnaires emailed at 1 week, 3 months, and 12 months. So at least one questionnaire response. Patients scored their outcome satisfaction, surgeon and hospital satisfaction, spectacle independence, and dysphotopsia on a 0 to 10 scale. Statistically, they looked at correlations. Correlations of PRIMs with outcome satisfaction were determined for the overall cohort and for eyes categorized by type of implanted intraocular lens. Current study results, the main results. Two 589 eyes from 119 hospitals, 26 countries were included for a response rate of 39.48. Among the 2589 included patients, 64% responded at 1 week and then it started reducing, 57% at 3 months, 26% responded at 1 year. As you're looking at this, the question, let's see, one of the questions to consider would be, is the response rate good enough? A 39.48% response rate, is it good enough? Now, usually for a questionnaire-based survey, 40% is a reasonably good acceptance or response rate. You don't usually get such a high response rate when it's a questionnaire-based survey. So you can say that it's reasonably good enough. Yes, is it high enough? Well, it's not exactly high enough, but yes, it's understandable. It's a questionnaire-based survey, and yes, 40% is not bad. Usually you get in the range of 20 to 30% or even lower. So it's reasonably good enough. Another key aspect to look at in that first statement would be you have 2589 eyes from 119 hospitals and 26 countries. That's a wide spread. It's a wide dispersion. It's a wide range of patients from different countries. And so, even though it's multicentric, the strength is supposedly multicentric, you're not getting too many patients or too many eyes from all centers. So, is that multicentric really strong enough? That's one thing that you need to consider. 2589 eyes is probably bread and butter from a single hospital in our setting. They needed 119 hospitals and 26 countries for that. So that's something that you need to consider. Again, the response declining over a period of time is also understandable. That's also a pragmatic reality. In terms of results, at 3 months, mean spectacle independence was greater for distance than for intermediate and near vision. The mean daytime and nighttime dysphotopsia scores decreased slightly from 3 months to 12 months. Mean outcome satisfaction was maintained at similar levels from 3 months to 12 months. So outcome satisfaction is almost similar between 3 months and 12 months, right? Dysphotopsia is a problem, 3 months to 12 months. Spectacle independence, greater for distance. In terms of target refraction, outcomes are compared between patients responding yes and no to target refraction questions. At 3 months, patients who are not sure, that 17.2% were excluded from the analysis. You can exclude them, but you also, when you're interpreting, you also need to consider, well, what if I said if they're not really sure that the answer is yes to those particular questions, should I consider that as no when I'm doing the analysis? If I consider that as no, and now I have just two binary categories, yes and no, which they have no, but that's after excluding the unsure. But without excluding the unsure, would it impact the results that are present? So you need to be thinking over that particular aspect. If they're unsure, is it when we have a response category of unsure in a questionnaire, when we are analyzing it, should we consider that unsure as well? If it's not yes, let's consider that as no when we are doing the analysis. So that's something to just keep in the back of your mind. The yes group had higher outcome satisfaction at 3 months and 12 months. That's after excluding the unsure. So would that change if you have included the unsure as no? That's one thing to think over as you look at these results. While near distance spectacle independence at 3 months was comparable, P is equal to 0.043. So it's just sitting on the borderline there of statistical significance. Greater spectacle independence for distance and intermediate vision was observed in the yes group. Lower daytime and nighttime dysphotopsia scores were noted in the yes group at 3 months and 12-month time points. So even if the response to the target refraction question was yes, they're still having lower daytime and nighttime dysphotopsia. There was no statistically significant differences in spectacle independence, dysphotopsia, outcome satisfaction between hydrophobic and hydrophilic lens material. When you compare monofocal EDOF and trifocal IOL, spectacle independence scores at all distances were highest with trifocal IOLs. There was no significant differences in daytime and nighttime dysphotopsia at 3 months, daytime dysphotopsia at 12 months, and outcome satisfaction at 3 months and 12 months. Looking at the correlations, outcome satisfaction showed weak to negligible positive correlations with spectacle independence. Outcome satisfaction showed strong to moderate negative correlation with daytime and nighttime dysphotopsia. So dysphotopsia, either daytime or nighttime, is a factor that is impacting significantly on patient satisfaction after cataract surgery, and it's strengthened at 12 months. At 3 months and 12 months, there was a moderate positive correlation with surgeon and with the hospital. So if you're a surgeon, you better talk well with your patient, keep them happy. At 12 months, outcome satisfaction and dysphotopsia showed moderate negative correlations in the yes group and strong negative correlations in the no group. So dysphotopsia is coming again and again as a factor that is impacting on outcome satisfaction. Spectacle independence is not so much of a factor. There's a strong correlation with a moderate to strong correlation with with the satisfaction with the surgeon and with the hospital. The hospital is a location where the surgeon is, as well as other possible benefits that the hospital environment and setting provide. So those are two factors that are playing a role in outcome satisfaction. Dysphotopsia is something that is impacting or lowering outcome satisfaction. The IOL type, satisfaction with all IOL types showed strong to moderate negative correlations, again with dysphotopsia. Negative correlation of outcome satisfaction with daytime dysphotopsia strengthened for all IOL types, while negative correlation of outcome satisfaction nighttime dysphotopsia was slightly decreased for trifocal and EDO of IOLs and increased for monofocal IOLs. So you're finding a slight difference in the type of IOL with nighttime dysphotopsia. And you need to consider why that might be so, right? Now, how do you then interpret these results? In the first place, I'm not a big fan of correlations. I'm not a big fan of using correlation for this, but that's what they used, and that's fine. But how do you then interpret these results going forward? What factors must be considered? One, it's a retrospective design. So are there limitations with the retrospective design? They had about 6,500 77, I think, eyes that were there in the database, of which they got responses from about 2.5. So it's about 40%. 40% response rate is not bad, but you need to consider, are there differences between non-respondents and respondents? Would it be nice to have seen whether there were clinical differences between respondents and non-respondents? Can that help us give a clue about how the non-respondents might have felt? Would the non-respondents possibly be not responding because they are completely satisfied, and why should I waste time on a questionnaire survey? Or are they not responding because they are dissatisfied and well, I have gone and spoken and tried and I'm not happy with the response, and I don't think this is going to make any difference by responding to this particular survey? Or are there no differences? Are there differences in the baseline characteristics? So we are having a wide range of inclusion criteria for cataract surgery, but we are not having any information on the baseline characteristics, right? So that can give a context actually. That's not there. It's fine. Are the large number of centers and possibly fewer patients per center a limitation? Questionnaire validity and reliability. Do we need to consider that for a study of this nature? Well, ideally, yes. But if the questions are quite simple, then do we need to look at? Why do we look at a questionnaire validity and reliability in the first place? It's primarily to see if the responses that are being provided are actually valid and reliable. And if you repeat it, would you get the same responses from the same set of patients? Or are the response categories actually telling something else, measuring something else? Are the responses something else than what is intended? So it would have been nice to have some information on the validity and reliability, but it's not there. That's fine. Baseline visual acuity for which cataract surgery was done is not there. So when we say about expectations, again, the problem for which cataract surgery was opted for and baseline spectacle dependence information is also not there. When we say cataract surgery, many years back, when I was more obese and had a little bit more black hair sprinkled in between all this gray mass, I'd seen settings where cataract surgery was being done with IOL implantation outside India was being done for cases with 6/6 vision. But the primary complaint was not, or even 6/9 vision. The primary complaint was not visual acuity. For other visual difficulties that they had, especially while driving and doing tasks and things like that. So with glare and photopsia and things like that. So it was not primarily entirely only for visual acuity. Having information on the baseline visual acuity and how that impacts on satisfaction. Now, if your baseline visual acuity is 6/6 or 6/9, and we're looking at spectacle independence, spectacle dependence, and satisfaction with visual acuity, if that is not a primary complaint, then is that really valid to have that response there? Something to just consider. Should we look at target refraction or target visual outcome? Is visual acuity the only complaint? Impact of cataract surgery, 6/9 or even better visual acuity and outcome satisfaction. Again, visual need-based IOL implants, different counseling, different expectations, and hence differing responses as the patient reports their outcomes. Entirely valid for that particular patient. But when you're translating that to a group, then how do we interpret that? How do we factor that aspect into it? So if you're someone who needs a good near vision for an activity, let's say a weaver or a tailor in our setting, or someone who's working with clocks and watches and needs very good near vision as opposed to someone who is grazing cows or grazing sheep or grazing goats and is more interested in distance vision. The satisfaction measures, do reported satisfaction measures differ there based on the need, the type of IOL that we put in. Would it differ there? So how do we build all those factors into it when we are trying to interpret the outcome measures? Again, impact of comorbidities on visual outcome expectations. Not necessarily that the comorbidity can impact negatively. It can also impact patient expectations in that they feel that, well, this comorbidity that I have, whether it's in the body or in the eye, has so much problems that even a slight improvement in vision is good enough for me. I'm satisfied with that. Even maintaining vision, I'm satisfied with that. So how do we balance those things? And that's why some more background information gives us a better idea of looking at the context in which these results can be interpreted. Now, as we look at all of this, the thing for you would be to then say, when I am doing a cataract surgery in my practice, what am I aiming for? What are the patient expectations? What am I aiming to provide? And there's a balance between a clinical expectation and there's a balance between a patient expectation. There's a balance between relying only on a patient need for a certain aspect as well as a clinical need to intervene, right? So all those things come into play. So having background context is always important when you're trying to interpret results such as this. Patient-reported outcomes are the subjective or objective. Does everyone look at the or similarly define dysphotopsia when they say that I have a problem? Again, what level of problem? People would call it in different ways, right? But when you're looking at, you can say I want it standardized, but when you're looking at patient-reported outcome measures, the key point is that that particular measure that they're reporting is important for that particular patient. So whether it's mild for them or severe for them, they're reporting that as a group, whether it's mild or severe as a different issue, right? And again, having baseline inputs for each person and then comparing what's happening on a pre-post basis would actually give you a better context for what is there. The importance of physician-patient communication and comfort is validated here, and it plays an important role. That's something that is intuitively known and recognized. The comfort with the physician, the comfort with the hospital setting can minimize the discomfort in several aspects. It can also help temper expectations. It can also help keep expectations pragmatic and realistic. And that's an important point to keep in mind, that when we counsel or talk to the patient, that we keep expectations pragmatic and realistic so that at a later stage it doesn't backfire. So moving forward, PROMs after cataract surgery in Kerala, what's the experience of clinicians here? What's the goal of cataract surgery from your clinical context? Is it primarily visual? Are you moving towards addressing other aspects and not necessarily only visual acuity? And how about preoperative expectations? Are we looking at functional visual expectations? Are we looking at visual expectations? Are we looking at realistic expectations? How are we tempering those expectations? And how are we recommending IOLs, balancing with those needs? Is it a clinical, how do we balance the clinical need about what might be good versus the functional, visual, or realistic expectation or preoperative expectation from the patient? Some aspects to consider. So when you're looking at a paper like this, it's sometimes very tempting to get completely caught up with the statistical part of it and say, well, there's a correlation, it is 30% correlation, 0.3, that is good. Is 0.3 a good correlation? 0.5, is it good? 0.2, is it bad? Is it poor? That's just one part of the puzzle. That part of the puzzle must always be taken out and placed in the context of what is clinically plausible, clinically realistic, what's happening in a clinical setting. And then you need to always balance statistical significance with clinical significance. And then look at all the aspects that can impact on interpretation. We can say that that was not done, and hence the study is bad. It's not the way to look at it. The way to look at it would be that was not done. If that is not there, how does it impact my interpretation of these results? If it was prospective, would it have been better? It might have been better. Now that it's retrospective, I'm not going to change that. So should I keep in mind that, well, there might be difficulties because of the way people are reporting. There might be difficulties in standardizing. There might be difficulties in response rate. What information can help me interpret it better? Can I then take all of this information that I have and then say, when I'm applying it to my patients, is it good enough for me to start applying? For this particular study, the question would be, do we look at PROMs? Do we need to look at PROMs? If we want to look at PROMs, how do we go about it? And is it really something that we want to do? Do we want to go down that path? And then again, the aspects of how do we choose the clinical intervention? How do we balance it? And open to the clinicians to take it forward.
Thank you, Dr. Praveen. It was a wonderful extrapolation of that article into the Kerala context, especially towards the end. And thank you for leaving us with those questions from which I can start a meaningful discussion. So let's take this question of which are the patients who might really benefit with or really need spectacle independence. I think we will open with a question to Dr. Minu Mathil. So, Dr. Minu, can you tell me, in your practice, who are the patients whom you select as good patients for this sort of premium IOLs and who may probably benefit more from spectacle independence? Are there any objective criteria for your patient selection or subjective criteria?
Thank you, Dr. Latika. And good to see Dr. Praveen here because he had joined Aravind when I was also there. And then he started the research boom in Aravind, which was not happening in Aravind because we were all just high volume surgeons and volume surgery was being focused on. And as far as your question goes, the criteria for selection is the selection is now, as I can tell you, the age of cataract patients is coming down, and the expectations of patients are different. So, like you cannot always say that patient wants only distance vision. That condition is gone. But there are different types of patients. So each type of patient has to be talked to and discussed to, and found out what they are expecting. And then for selecting for premium, see for them the lens which they choose is premium. For us, we call it premium because it is costlier, because it is new technology. New technology does not mean that that will be good for that patient and he'll feel happy about having hair. There are a very small segment of people, especially I've seen in the West, who are very happy about having the newest thing in their eye or newest thing getting implanted into the eye, and they feel happy about it and they are okay with whatever negatives it has. I have seen directly. So that is a different issue. So selection wise, premium IOLs, if you call them as the EDOF and the multifocals, which are beyond the monofocals, I would say till advanced monofocals or monofocal plus and EDOF, any patient can have those lenses who can have a monofocal. But the criteria for multifocal or trifocals are very strict and stringent. We all know that there is a list of criteria where we should exclude people from having multifocal lenses. So, including the corneal surface, including the astigmatism, including the optic nerve pathology, retinal pathology, irregular corneas, patient very unrealistic kind of expectations. All these patients have to be excluded. That we have to tell in the beginning itself, and that is my criteria. But all the other lenses anybody can have, including a toric correction if they need a toric correction.
Thank you, Dr. Minu. Dr. Marin, would you like to add on anything to that, or is your take also the same?
First of all, thank you, Dr. Latika, for having me here. To a large extent, yes, I agree with what Dr. Minu has said. But definitely, I prefer even to really counsel, chair time, I think is really very important. And definitely, I avoid, all these, the multifocals, especially in those patients who are having any kind of macular pathology, or if they have, because see, when you are, when like he said, premium is in our mind, but we are projecting our expectation also to the patient, because we tell them that this is a premium, and what do you expect out of a premium is that the results will be better because you're paying more. So that kind of expectation, I believe we are setting it up in the patient. And so therefore it's very, very important that we temper those expectations, especially even if it is doctor was saying just now, that you can think of an EDOF lens in even in any patient. But even in those patients, I generally take more time to explain to them that even though you're going for this, your expectation should be tempered. So yes, I think counseling there, especially hands-on counseling by the surgeon, is really very important.
Okay. So I think both of our clinical experts are more or less in agreement regarding that question regarding selection of patients. So now coming to the different kinds of patients who come to you. That is, sometimes you are dealing with a patient with cataract only in one eye. Sometimes it is a pseudophakia in one eye and the cataract in the other. And sometimes it's a patient with cataract in both eyes. You are considering one eye first. So how would your approach to and the patient you think is a patient who needs or who can benefit from spectacle independence. So, how would your approaches and counseling vary in these three different sets of patients?
The question to me, or
It's a question to you, Dr. Mohan.
so as far as I am concerned, technically we would, like, initially we would say, like, if it was a unilateral cataract, you better avoid like multifocals. You go in for an EDOF or a monofocal, because you want to match with the fellow eye to avoid dissatisfaction. But given the current scenario, most of the patients, you tell them that you will get, especially if they are young. I have found in my personal experience that even if they have a unilateral cataract and they are less than 40, have not experienced presbyopia, you have given them a multifocal in those eyes, many of them are satisfied, because you have explained what to do. But the the teaching is that it is better to avoid it in unilateral cataract. Similarly, if the pseudophakic eye, if the other eye is a monofocal, you can aim for, especially if that is the dominant eye, you can aim for with an EDOF lens. They do very, very well. Ideal cases, of course, are the bilateral cataracts, in which you want to do quickly, a quick succession, so that their neuroadaptation comes on very fast. So in bilateral cataract, there is no controversy. The other two, I think Dr. Minu can add what his strategy is.
Dr. Minu, what is your take on that?
See, this unilateral cataract, it is again what a patient can expect. If see, the problem is you can implant any IOL, but the problem is there is a sect of patients whose cortical adaptation.
We have lost him momentarily. Dr. Minu, I think we have lost you there. Yeah, maybe we can. Yeah, he's back. Yeah, we had lost you momentarily. Glad to have you back. Yes.
Muted. No, you're muted.
Minu, you're muted.
Unmute. Okay. So they will be permanently dissatisfied. So a very great chair time working with them is very, very important, but still I would exclude because who will fall into that, we won't be able to know. So an EDOF actually works quite well without this, because if you tell them that these are the problems which you can face with the unilateral which you can, not that you will, you may or you can, then they will take the informed decision. And most of them will say they don't want. So that is what. But if they insist, it is always fine. You get it written down from them that these are the possible things, and if you do not want, you can. There will the option of an exchange is possible, which can end up with the difficult problems. All those things, if they understand and agree, fine. I have also seen unilateral trifocals doing quite well without any thing. That's a mental mindset is very very crucial. Then the other eye pseudophakia. Pseudophakia may be multifocal or monofocal. So a multifocal patient asking for a monofocal is the other way around, which is happening now, right now. Some people who are very dissatisfied with multifocal in that eye, asking for monofocal or EDOF, and they're extremely thrilled to have that kind of a lens in that. Again, it depends on what is their present situation. If it is a pseudophakia with a monofocal, and they say that it is very difficult for me to see near. So otherwise, my point is quality versus convenience. The quality of vision, which is better in monofocal, is slightly compromised when you move further away from monofocals. Very slightly in EDOFs, but to a certain extent more in trifocals. And so they have to know that. And if they are willing to agree to that for the convenience of spectacle, I want to insist that the word independence should be taken off, and we should say less dependence. I got from the Aravind pamphlet also, the day for yesterday, when we wanted to see what is being told in Aravind. It is written with an asterisk, 90% of the time, reduced use of glasses. So that is what is, you can even tell 95. But then I never say 100% or independence, because they never said, even in their website, it is not given, the
Yes.
lens is thing. So this word of independence should die. It should not be there. And bilateral cataract, according to the, see, many of the EDOFs, again, I wanted to tell specific about one thing, the study, it has only reported one eye experience. So as he said, we should not be telling that this is wrong, that is wrong. But in clinical practice, if you go beyond monofocal, it is always binocular which adds on. There is a summation for all these lenses. So uninocularly, if they have an N10, binocularly they'll have N6 parts if it is a proper EDOF. So many of them with N8 will read N6 clean with a little distance off, will read N6 binocularly. So binocularly, which the study which has not analyzed binocularity in advanced monofocals and multifocals, it is little biased in the results. So of patient not being happy with what is the visual outcome. But otherwise, these are the, as Dr. Mary was telling, these are the options.
So, I mean, to conclude the answers to that question, uh, in a bilateral cataract, the options are, I mean, it is more or less, there are no controversies, and you can go ahead with whatever the lens preferences, depending upon a conversation with the patient. But in the case of unilateral cataracts or unilateral pseudophakia in the other eye, you should be very cautious and spend much time in setting realistic patient expectations. And an EDOF lens or even a multifocal can work. It may not always fail, it can work, though not, it's not as advocated as in the case of a unilateral, as in the case of a bilateral cataract surgery. Yes, now coming to the, moving on to the other aspects, this question is to Dr. Minu. So, this is regarding the workup of cataract in such patients in whom you are considering these sort of presbyopia correction IOLs. Is it any different from our usual cataract workup? If a baseline cataract surgeon aspires to become a refractive lens surgeon, do you think that he needs to upgrade not only his skills but his tools and his equipment and his protocols as well?
Yeah, that is very crucial. See, there is no regular cataract surgery and regular and premium. There is no difference. Patients has to be evaluated properly. But there are sensitive issues which become more sensitive when they have this EDOF, very little in EDOF, but much more in trifocal. So those things have to be more keenly seen, identified, and treated, or corrected, or told to the patient that this may influence your outcome more than the monofocal patients. That is why it is more important. So assessing the ocular surface, more than 80% of your patients have some form of dry eye. MGD is the most common thing, plus a dry eye. If you directly look through the cornea, I tend to nowadays look through the cornea directly onto the lens. So that attitude should change. Once they have gone to the counselor and they have selected, they are opting for something like that, they immediately come back to me. So I evaluate them further for any dry eye symptoms. Then we ask for another day's this thing. Then the calculations will take multiple times. We use different machines and at different dates on a virgin cornea without any medication, anything. The readings are taken, and till we get repeatable ones and constant ones, we continue and get very reliable keratometry values. And the other thing is astigmatism correction. So I would tend to leave up to 0.75 in monofocals, but in EDOF and multifocal, I start from plus zero point 0.5, from 0.5. Including a 0.5, I will correct. I will run it in the Barrett suite or in the company's website. It will show a smallest toric, but which, if not corrected, will end up with dissatisfaction as far as outcome is concerned. The visual outcome without glass correction is concerned. And also macular pathology. Every patient should get an OCT. So patient should have people should have OCTs. People should have an optical biometer, and every patient I do a specular. It is very, very crucial that you do specular microscopy, and patients don't have some inherent pathology which can progress later, or even at that time it can cause mild corneal edemas or some scatter and all those because of gutte and all those things. So these kind of subtle investigations have to be repeated. They come back to me for investigation and for further counseling, and then after calculating everything, they come back to me again. And then this is the kind of chair time which we are spending for EDOFs and not advanced monofocal. Advanced monofocal will work like this, and you get a 25% advantage on the intermediate, and it doesn't make much of a difference. But even advanced monofocals like monofocal plus the eye hands group, they also fare at least 20-25% more than the monofocal as far as near intermediate is concerned. So that also needs to be corrected. The astigmatism part also needs to be corrected, and OCT of macula of everybody and has to be shown to the patient, and they have to understand that this kind of a pathology or subtle pathologies exist which can affect the outcome is very crucial.
Okay, thank you, Dr. Minu. That means if you're considering such premium cataract surgeries, you need to add to your baseline evaluation of routine cataract workup. You must add specular microscopy, dry eye evaluation, OCT macula, even if you're not already doing it, and also go for a very stringent correction of astigmatism is what I understand. And Dr. Marin, would you like to comment on this further?
So in this, see, what Dr. Menu has said is the ideal situation. And we know that most of our surgeons work from far off than ideal situation. So my thing would be that if you're like, I don't know, I had done a study on optical biometry versus even ultrasound. And so the idea is that if you do something yourself, see, the problem now is that we have, given offshored all these investigations to the optometrist and all the other people. But if you as a surgeon sitting in a peripheral center without access to all these, fancy tools, can still do a premium IOL, provided one that is non-negotiable is a macular OCT. That is non-negotiable. All the others that Dr. Minu said, you can do without if you have a good keratometer, manual will still work, but you have to do these things yourself. You have to do a good ultrasound biometry. You have to again recheck, and it's not easy, but it is not that it cannot be done. It can be done, but it will involve a lot of time and lot more time counseling the patient. So don't set up the patient expectation so high that they'll come back and bite your head off if you have say a small difference from the target refraction. But you can start your practice from there. But to me, the only non-negotiable is a macular OCT.
Okay, so that means our clinical experts are slightly differing there in their messages to the aspiring cataract surgeon. The ideal would be what, as Dr. Minu said, the armamentarium should include anything from an optical upgrading to an optical biometer to a specular microscopy. But in our practical scenarios where people run individual setups, so one doctor establishments where it may not be always possible, one can still go ahead and probably start off with EDOFs, right? Or extended depth, extended, I mean that what intermediate vision enhanced monofocals before doing the other more advanced sort of trifocals and multifocals, and get away with it as Dr. Minu was saying, and then gradually, probably as their practices allow, the ideal thing would be to go the way that Dr. Minumathan has just explained, but it should not deter you from, aspiring for more, as Dr. Marin Paul was mentioning. Yes. So,
Well, just to add that I was not talking about an imaginary or a totally not possible situation. It is happening in my practice. It may not be possible. I know it is. These are costly things, but if you are doing a high number of this kind of high-end EDOFs or multifocals, it means that your practice is also premium. It is not that you are sitting without any possible or just like that one tonometer or whatever. So we should be because we should not get deterred from using these lenses and providing it to patient by getting bad results initially.
Yes,
So
I agree.
blaming
That's
on the lens, blaming on the surgery and all those things. So when you are ready to go into this, make sure that see immersion is also good enough. And if you do a good keratometry with your regular keratometer, that is also good enough as a skilled person. When Dr. Marin is skilled, as per I am dependent, I depend more on my skilled. They are posted in my unit for multiple years, and I know that they are much better, and I can depend on them. So dependable person, either yourself or a person whom you are dependent on,
Right.
depending on,
totally,
not dependent
totally
on,
agree.
depending on, and these kind of misses. See, even my practice, the number of the multifocals are much less, much less. We are not left and right using it on this one. See, patient may not tell many things, but then they may what they tell outside will be a different issue. Expectation if not met. So if the expectation is that, we should try our best to meet the expectation, and the bottom line is a touch up with refractive surgery. So this is what has to be told to a patient who says I will not use glasses. So we have to tell that it is not a 100% thing that you will not end up with any power. I will try the best to do all this, and if you end up with this minimal powers, it can be touched up with the refractive procedure later on if you are adamant on that. That all these things should be written and signed from the patient, and then talk about it later. Later on, talking about it because you have not done or the small things which have been excluded, it will be very difficult to talk to these kind of premium means they are paying close to 1 lakh or something like that. And if then they pay something like that, and then their expectation will be very high. So that has to be talked to, and as Dr. Marine said, if you temper them down, then it is fine. But if they are still sticking on to this, I would say please don't do without correcting the dry eye, or without correcting the astigmatism, and without doing an OCT of the macula.
Okay. So I think things are rather clear from this open conversation that we have had. So it depends on how much the cataract surgeon really wants to go premium on their results also. So yeah, so that's what it is. And now coming to the next aspect of this discussion, this question is to Dr. Minumathan. So we have an array of lenses coming out. It's almost very confusing to that is, we have the EDOF, we have the multifocal, we have the trifocal, we have the monofocal with an extended or an enhanced intermediate vision. So of these lenses, how do you actually do this IOL match making, the so-called IOL matchmaking to the patient? Which patient needs which lens? What are the considerations that you take into account while deciding that? Are there any tips? Is there any algorithm? Is it personal? What is your choice? How do you go about it?
So if the cost is not a problem for a patient, any patient can have an enhanced monofocal. Any monofocal patient, if it's a little bit more of money, they can have that. No selection criteria, nothing. So from there onwards, with any patient having a more than 0.5 cylinder, should be given the option of correcting with toric, so that the outcomes are. Outcome means if the patient wants. See, I had a patient yesterday, a day for last week, one eye done, and his wife did both the eyes last month, and he had negative dysphotopsia. Both eyes of the lady did not have. So he had 6.6 with N6 with an VVT. I would say no financial interest in company name. But he said, I have this. Then he said, I have Googled it and found out that this is this. It is okay. I know that it will may go off by this thing. But this is what I did not actually tell him about negative dysphotopsia. So the first thing he told me after this one was negative dysphotopsia. Wife doesn't have this. So again, the point is choosing something and missing to tell something is nothing. We can just tell like that, forget it. But this is one thorn which will prick you after doing the best. Again, I should tell you, you should do the best possible surgery also. You cannot do a lax surgery and decide on multifocal lens just because the lens is inside, and you cannot do that. So if you move into the kind of this thing, you should be in a state where you are able to give very consistent results as far as your rexus is concerned, your IOL implant in the bag, and the section, everything is concerned. And once you go beyond that, again, it's a question of what is the expectation. If the patient is fine for wearing glasses for near intermediate and see, I would say for the actual EDOFs, I use only two particular companies imported EDOFs, because I don't believe in companies which give variable results with this one. So I don't want to tell that this maybe variable may happen kind of thing. So I stick on to what has given good results for me. If it is N10 to N8, they will read N6 parts with both eyes.
Yes.
And mostly they are N8. And with enhanced monofocal, they will be close to N12 to N10. And they may read N8 without glasses, but definitely not N6. Some read, but that is not a sure thing. If it is not that, they will end up with N24 or N18 or whatever. So that is the point which I tell the patient, and they have to choose. They have to choose. These are the possible things with spectacle independence. So spectacle independence is not at all important for some people. They say, I just want to read clearly. I just want to see. Glasses is not at all a problem with me. So the quality part is very important. I do not want to see glare. I already have glare. I do not want anything which gives more glare. So give me something which gives less glare. I do not mind glasses. So please ask them. Independence of glass, everybody would like to have independence of glass, would like to have. If you tell them that glass independence is or less dependence is there without any other side effect, then everybody will opt for that. So you should always say that there is a negative and a plus for every lens, and it is up to the patient to decide.
Okay. Dr. Marin, would you like to add on a word about the trifocals and the multifocals? Which are the patients you think would benefit more from that over the EDOF?
The trifocals. As far as trifocals are concerned, I always spend maximum time for trifocals, because these are I just keep them for patients who are prioritizing full near vision, not full near vision, who have a priority for that. Those are, to me, in my mind, the ones who should be counseled for trifocals. Because with an EDOF lens, which is what most, majority of my patients fall in the EDOF lens category, because they are like either working on the computer or and so over time I have found that, because EDOF is like for the last 4 or 5 years now that has come, and I've been doing these multifocals for a long time. So initially, like all those patients who were going in for multifocals, now the number for those trifocals or multifocals are coming down as compared to the EDOFs, because patients, like he said, are more willing to adjust, or because how much are people reading these days? Everybody is either on the mobile or on the computer. So reading as a hobby or as a near work as such is coming down. So I don't know how much of trifocals have, unless those are very, very specific people who will insist that I want to read without glass. Those patients, yes.
Okay. So largely it is the EDOF that is now on the boom compared to the multifocals, unless the patient has specific requirements for near vision. That is the take home here. And Coming to, one more question for you, Dr. Merrill. What is your endpoint, refractive endpoint of your surgery? Is it that you want to leave the patient as an emmetrope, or is it that you would like to have them as a slight myope, like minus 0.5, minus 0.75, or would you like monovision, or what?
So you see, the original full monovision is less favored now. So like, one eye for distant, one eye for near. But micro monovision is definitely possible, especially if you're, planning for monofocals. But in case of bilateral premium IOLs, like this thing, we always aim for emmetropia in both eyes. EDOF, and if it is monofocal enhanced, sometimes like I do try a little bit of a mini microvision in a 0.25 to 0.5 in the non-dominant eye. Dominant eye, we still aim for emmetropia. So that is generally my game plan.
Okay. Thank you. So what about Dr. Menu? Is it the same or is it any different?
Almost similar. Only thing is, most patients, they will just close one eye and see, just close this eye and see. And if you aim for this one without telling the patient, they will always say that I am not seeing similar with both the eyes. Okay, I can read better with this eye, but then both eyes together, when I drive, what will happen? I will not be able to see clearly. So before surgery itself, this has to be told, and the patient has to understand. I have had patients whom I have told on the table outside the in the block room that we can try this long back in monofocals. We can try this. He said, okay, doctor, why don't you try that? So such kind of easygoing patients are fine. But before surgery, to convince patient on monofocal seems to be little difficult. They'll say, we will go with this. Look, this one is looking very good. Distance also should be like that. So if they agree to that, but unknowingly, some people land up with that, and later on, they are very happy. One of my uncles, actually, he got one eye done. He is outside. So one eye accidentally became myopic. And initially he said, see, this was bad. Yeah, somehow something happened. Nowadays he is walking around without glasses and telling that, see, I can see everything without glass, man. It was so nice that it had happened and all. So it depends on the personality of the person and how you communicate it to the patient. And whichever way you communicate, it has to be communicated. That is very, very, very important. But I would say with EDOFs, binocularly 6.6 will be good if you correct the cylinder, and they will get near vision. And as Dr. Marine clearly, nicely pointed out, if they want N6 without correction, trifocals is the way. But they will be told about the glare and halos and all those things, and they don't care. They don't care. I don't drive in the night. I don't keep looking at the light. I don't care. But my main hobby is this. Well, another patient who came from Australia telling that I want panoptics. He still the name of the person also. I told him about the possibilities of glare and other things, and the EDOF possibility. Then he said, okay, I read always in an iPad, and I just enlarge the font and see. I don't have a problem. So he changed it to the EDOF, and he again became N6. That's a different. Binocularly, he became N6 with EDOF. But still he changed because he got to know about the photic phenomenon or the dysphotopsias of a trifocal in detail after talking to me. So that is how patients change, and we also should impart all these knowledge and information very clearly to the patient.
So in my practice, most of my multifocals are housewives who do not drive. So for them, it is really, and they usually like, they'll come like, because somebody else in the family did it, and they want exactly what the other person had.
Oh. So patients are different, so are their expectations, and it is the cataract, and that's why cataract surgery also becomes an art to find out what the patient wants, and to set the expectations realistic and choose accordingly, along with the many other aspects that have been discussed here. So now Dr. Minu Madan was talking about the photic phenomena and the negative dysphotopsias and everything. So, Dr. Marin, do you think that any particular IOL has an advantage in that aspect? Because in the study, it is mentioned that EDOF has a slight advantage as regards dysphotopsias. So, in your practice, how do the IOLs fare regarding glare and dysphotopsias?
My practice, enhanced monofocals, I think, have the most minimal dysphotopsias, and EDOFs are next, and then of course the multifocals will have some amount. But even because see, unless you do a proper aberrometry and look at all the higher order aberrations and all that, some even monofocals will have dysphotopsias. Now, the problem is positive dysphotopsias are not tolerated. Negative dysphotopsias, you can counsel the patient. It is their concern is valid, and you need to respect that. But you can tell them and that it's going to like come down. You'll get adjusted to it. But there are still patients who, like 1 year later, will also be complaining of negative dysphotopsias, but those are less in number. But yes, this is my general, impression about the different types of IOLs.
Okay. So, if a
Dysphotopsia,
patient
when
has
we
this,
call it, sorry, can I?
yeah, sure, sure.
When we call it dysphotopsia, the negative dysphotopsia is there for all lenses, any lens. And positive dysphotopsias are much more in trifocals, slightly there in EDOFs, and still minimally there in monofocals also. You can have this kind of a light going around this one, but these come down. These come down, and in these kind of lenses, and they are adjustable, but the trifocals are much more. The glare part, the halo part, the starburst phenomenon, all those things are unique
More
to
than
them,
that.
and they are much more also. So those have to be, we show them pictures. We show patients pictures of what they will see with these kind of lenses. They are really taken aback with that, and they don't choose. So that's what happens. But the EDOFs, although we claim that it is not there, but even in their pamphlet of the IOL, it is written. And so we can boldly tell that there will be some bit of it which will be minimal, which may not be that very, and every lens may have a little bit of it. And positive dysphotopsia is, as she said, is the one which is not tolerated well, and the negative dysphotopsia, even after 1 year, they'll come and say, "Adippudu undu keto." But they are not much concerned. Or the other one is that what is bothersome during their daily routine.
Oh. So actually, we have reached the end of our time. But since this is such a hot topic, and since we have such a eminent faculty here, I think we can take a couple of questions more. So in this study, it's clearly mentioned that spectacle independence does not guarantee patient satisfaction. In fact, there was not much of a correlation between the two. So, do you agree to that, Dr. Minu? In your practice, spectacle independence, does it lead to patient satisfaction, or they say that I have no glasses, yet they have a lot of complaints? Is it like that?
That's what. So again, the answer is, why would a patient come there? Why would a patient come to you, and have you addressed this problem? So if somebody comes with a defective vision, and you think that making them spectacle free is the pinnacle of your success, the patient will not be happy. Patient's happiness. Another thing is what, when I heard in another talk, you cannot make anybody happy with a cataract surgery. So making somebody happy is not a satisfaction of outcome of what he had, what problem he had. The correction which you have done is what matters. So first question I ask is, why have you come? What is your problem? So without that, you telling showing cataract, vision is low. Okay, you will do cataract surgery, and spectacle independence is the ultimate thing. That is a wrong concept for a major group of patients. But some group of patients are fine. But I would say, asking the patient that whether you need spectacle independence, you need a vision which is of better quality and clarity, which is your priority, and we cannot give everything in one lens, and there are
Yes.
variations in lenses which I will tell you, from which you need to take and pick and choose which is concerning. Because in this study, they have told that they have started from 18 years and above. So
Mm.
multiple causes for cataracts are included in this study. So, and we also having patients coming from 40s itself having cataracts. So everybody's expectation is different, and their kind of work is different. And as she said, everybody is not just like that reading all the time. They are doing functional. That is the question of functional near vision,
Vision.
functional intermediate vision, which has come up so very much, and patients are accepting. And all these EDOF patients are quite satisfied with what they have if they know exactly what is going to happen. Many of them some people wear glasses for the look of it. I know people telling that I have glasses frames which are very costly ones with me. I want to wear glasses. It will hide my whatever thing which needs to be hidden. And there are many things which will come out of patient if you ask for why they have come and what they want out of cataract surgery. Also, please include the opinion of the spouses. and the people who are paying for it also. Very, very important in our context, in Kerala context. Not like in the West where everything is free and there is nobody else to comment on their what they particularly want, and they insist, I want this because I need this for my daily, I am alone, I need to do this, that. Here again, spouse is very important, and also the family member who is spending money on this is also very important.
Okay, so very practical points there. And I think we'll go on to the last question of this discussion. This is to Dr. Marin. So, this concept of patient-reported outcome measures as a routine part of clinical practice has come up in this article, and it is now, it's now coming up on a big scale also. So, do you think that it is time to incorporate PROMs and at least email-based questionnaires in our practices also? Do you think it will work? And do you think it's worth taking that effort? And also, as Dr. Minu Martin was saying, visual acuity is not everything. A functional vision assessment is also important. So, do you think that our present outcome measures, which are largely confined to the visual acuity part, should extend beyond to functional vision and even PROMs? Is it feasible?
So, okay, let me put this with a caveat. When we talk about what is feasible and what is desirable, these are two different things. Now, from a desirable point of view, we should not be looking at visual acuity alone. We should look at contrast sensitivity, night vision, visual comfort, all these things will form part of the PROs, right? So when we form, protocols for cataract surgery or any other surgery for that matter, we take into account a lot of things which are feasible or what we can deliver. Deliverables are what we look at, right? Now, what does the patient want should be our end goal, but not always feasible because different patients will want different things. So taking all these things into consideration, we should target getting PROMs in our daily practice. Given our volumes, given our financial limitations, it may not always be feasible. But definitely looking into incorporating these into our future practice, or taking at least one or two steps. See, a full questionnaire like you saw in the study itself, many people will not be interested in giving your feedback. But you can ask like 2 questions or a hybrid model where it is not on email or like this thing, but you can just, just after the surgery, ask them to fill out a form with just 3 questions. Such things are feasible. Definitely, it should be within the realm of achievability. But in busy practices, these may not be feasible. And in non-busy practices, you will not have the enough patients to do this. But definitely should be on our target. That is what I feel.
Okay, so Dr. Minu Martin, would you like to add on to that?
Definitely, new lenses which have come, we have information only from companies and company-sponsored studies. So it is very crucial that we get information from patients, individual opinions of what has happened to their lifestyle and their outcome after these lenses. So every patient I ask. So from them only we will get information on. We can check only 6/6. We can check only maybe contrast sensitivity also. But what happened during their lifestyle, for which all are they comfortable, which all was better before, because younger stage, reading speed, the dim illumination vision, and during driving or night activities, the distant all these things will come from patients who are in different age groups and different occupations. So
that
from
is regular feedback you are talking, oral feedback which we take from our patients. What
yes.
PROMs would be like proper structured answers which you are like feeding into a computer.
Exactly. So that may not be practically possible in every patient, but one or two of these questions which are affecting, which are important changes which have happened in the research should be incorporated into the electronic record. We type it inside. We don't have have a questionnaire, but then we have just now started a study for thesis of a PG student. This is the study.
So,
This is the study. I have to ask her to join in this session also and to listen.
so actually, this is the point that I wanted to highlight. So in a PROMs, see, ultimately we are clinicians, and our ultimate goal is patient satisfaction in whatever realm that we are working in. But without taking a proper assessment of how satisfied our patients are in whatever manner, it is not possible to go forward. And it is high time that we incorporated it into our practices in whichever way it is feasible. Probably we are all doing it in informal ways, but since we have a research culture also coming up parallelly, it is very good that Dr. Minu has already started a study on PROMs in cataract surgery. So such things are needed to formalize this type of feedback. And as we have all learned, patients are our best reference books, and that can be put on record only by proper structured studies. So that is one area where research can add a great value to practice. And it's a good research gap right now in our scenario related to this theme. So both clinically and in research, from the research point of view, I think it's important to, it's high time that we incorporated PROMs in practice. So Dr. Praveen, would you like to add any comments?
Comments on? I think several
On the discussion before I conclude.
on this discussion.
Yes.
Oh, I think several important
Anything,
points were raised. And one of the points that Dr. Minu said is correct. It's very appropriate that the source from where we rely on information is important. And by not generating our own evidence for whatever reasons, by not generating our own evidence, we're actually limiting ourselves to the what is available, and probably has its own bias and agendas behind it. One reason why we wanted to start this series when Latika tapped me in the beginning, was that we wanted to take what we call as research from a purely statistical, mathematically loaded phenomenon into something that can be and must be translated into clinical practice. And how do we do that? That was the idea of analyzing the articles in a completely different manner, as opposed to looking at it from a purely statistical point of view, that bringing in questions that you can reflect on. If you are a viewer, there are few things that you need to consider. One, that most often we tend to believe that any research study must come only from an institution in whatever sense. We disregard the experiences, the clinical experience of individual practitioners. We don't see them as equal partners or stakeholders in this whole thing. Either it's a limitation from our side, or it's something that comes from their side, that they feel that they should not be doing it, or they're not worth doing it, or they step back from that, saying we don't have time for that, or whatever reasons there is. But when we are doing that, we are actually missing out on a lot of experiences, like how we want to collect PROMs. We're also missing out on the experience, the individual patient, individual clinician experiences. Institutional experiences with the support of wonderful technology and a large number of support staff is going to be different from someone who is sitting alone in a setting with one or two staff, who keeps getting married and leaves, and you train and retrain and all those hassles of all those things, and you have to break your head over administrative balancing your bank balances, GST, IT, ED sitting on your head, all those things, lot of administrative headaches. So that missing out on the ICE, the individual clinician experience, is something that is distracting us from achieving optimal results. So along with patient experiences, which we must consider, I think that we should also consider, and we should also include and welcome individual clinicians into the whole scene. It's not happening, isn't it? Even if you look at KG articles, or if you look at IG articles, or if you look at any articles, or even talks, anything, we have an institutional bias. That's where most of the work comes from. And so that is natural that it moves along that same. But that means that there is a particular direction in which the entire clinical care moves without necessarily including, I'm not saying it's excluding, but without necessarily including 90% of clinician-patient interactions and outcomes. So if we want to tell the patient, if we want to counsel the patient that this is what is good for you, can we counsel the patient based on objective data from our clinical experience, as opposed to data that is coming from either a company-based study, an institution-based study, or a study that is coming from a setting that does not reflect your clinical practice? Right. So in this particular study, it's coming from primarily from UK and Europe and from US, and their patient expectations. We would like to say that our patients have the same expectations and we are developed enough for that. But pragmatically, even culturally, even in terms of function, our needs will be different. So translating that from there to this, to our setting, and then giving the counseling, do we have enough, can we develop enough backup support to sit there? Now, at an individual level and even at an institutional level, PROMs are not going to be easy. But is it possible to set up anonymized databases where patients can report or can access questionnaires and can report on it? It may not be perfect, but it can be something that the KSOS can think of. Can we set up something like that where patients can say, I had this surgery, answer questions? It can be post-surgical, it can be post-medical interventions, it can be subspecialty wise, and it can be voluntary opt-ins. And you can just say that you can report your outcomes there and it helps us define and see what's happening. It will have a lot of bias in that. It will happen. Maybe only those who feel very offended will enter in and do something. Those who feel happy will not do it. But it's something that can set the path rolling about considering multiple options. But two things I see here. One, from the curriculum level, from the thesis level, we are looking at research as something that is separate from clinical practice, which it's not. Two, that we are not including the vast majority of clinicians in the dialogue or in the process of reporting their outcomes. As important as patient outcomes are, it's also important, I feel, to get what do individual clinicians feel about their outcomes on their patients, and not an informal discussion that I feel, because we'll remember only the very good and the very bad. The gray zone 90% is something that it's in the middle, which we will never recollect. It's just the way the human mind is. You remember the excellent, you remember the very bad. The intermediate one is where the fun lies, but that's what we don't miss documenting, and that's what we miss entirely when we miss out. So if you are an individual practitioner who has taken the time to listen to the experts, and there's a lot of pearls that came in there, you must consider, well, in my practice, what am I seeing? Even if I'm documenting it from 1 or 2 to start with, can I document and see what's really happening in my practice? Is there a way for me to start sharing this and then say, collecting information and expanding upon it? That is the way we must integrate. Without integrating it, we have spent decades doing ophthalmology research, any medical discipline research. We have spent decades. We still battle with huge numbers of adverse consequences from our population. We still battle with not being able to tackle these problems. And much of it happens because we really don't have data from the vast majority of people who are practicing clinical medicine. Whether it's ophthalmology, whether it's any medical practice. If we are having data, we get it from the big institutions. Right, and then we rely on them to drive the whole thing. I'm not against that, but I feel when you're excluding 90% of the population who are practicing, you're missing out on 90% of the information that might make a difference. And that's something that we need to consider. And when we start considering that, then we can be less dependent on all this statistical jargon and complex statistical tests and mathematical modeling and stuff like that, and bring it back into maths and stats supporting clinical acumen and clinical practice, rather than going the other way around and saying if it is p-value less than this, then it must be done. If it is p-value, it should not be done. And it reshift the paradigms. That's all. I think I was wondering why the bloody hell did she ask me to speak. I took my
How did you
revenge.
know that? Okay, anyway, anyway, no, I mean, you don't speak often, so we know that it's worth listening to your words. That's why I invited your comments. Uh, so thank you for those, for the wise counsel, actually. And we are concluding not only this session, but I'm concluding this entire series here. This was our last episode of the KSOS KJO online series on evidence-based practice. And we are leaving you with this very wise advice from our research mentor. As he said, it's extremely important to have individual clinician experiences incorporated into our research jargons and into our research databases. If we are to have authentic references which are relevant to our own practices. So I hope this series, which has endeavored to blend evidence with experience, has triggered some interest in that direction and will spark some studies at least going through the episodes. All these episodes are available on the YouTube, and those of our viewers who have not already watched, those of our members who have not already watched, can anytime access it. And if you have if you actually watch it with an intention to spin a study out of it, or to put in your own clinical experiences into it, you can do that if you watch it with that particular frame of mind. So that was the intention of the series. And naturally, though the webinar ends here, the quiz becomes live after this episode also. It will be live on the website for 2 weeks for this episode too. And we will be closing it only after the quiz closes with the KGO collectible flashcard that will hit your inboxes roughly 14 days from now. So that will technically be the last step of this webinar series. So it was a real pleasure for me to put together this novel approach to a journal club rather than the conventional approach to that. I enjoyed it thoroughly. It was a great learning experience for me, and a great platform to interact with such clinical experts as well as our research mentor. So I hope you all also enjoyed it as much as me and Dr. Praveen did putting this together for you. I am only the anchor of the show. Dr. Praveen is the real anchor of the series here. So thank you so much for being with KJO. And thank you, Dr. Marin and Minumathan, for being here and we had a very scintillating hour of discussions. I'm sure that our viewers would have benefited a lot. Thank you all.
Thank you very much.
Thank you. Thank you for having me. And thank you, Dr. Praveen.
Good to see you, Dr. Praveen.